Bismillah ar-Rahman ar-Rahim. Today we are going to discuss one of the very hot topics, especially in the pediatrics respiratory failure. So our journal topic today is the inhaled nitric oxide used in the pediatric hypoxemic respiratory failure. And this was published in the Pediatric Clinical Care Journal of Medicine in August 2020. And the senior author was John T. Berger et al. What was studied in this article, their main objective was to characterize contemporary use of inhaled nitric oxide in the pediatric acute respiratory failure and to assess the relationship between clinical variables and outcome. They thought they have to study the relationship of inhaled nitric oxide response to patient characteristics, including the right ventricular dysfunction and clinician responsiveness to improve oxygenation. So this was what is special, which drew my attention to this study, that they studied the right ventricular dysfunction in relation to the use of the nitric oxide. We hypothesized that prompt clinician responsiveness to minimize hyperoxia would be associated with improved outcome. So here mainly they are seeing how fast the clinician will start doing the FiO2 for the patient once his oxygenation will start to improve, and whether this prompt response will improve the patient's outcome or it doesn't improve. The study design and setting. This was a cohort study observational study, and this was from 8 centers of the Collaborative Pediatric Critical Care Research Networks. So this is one of the largest studies about the inhaled nitric oxide use in the pediatrics ARDS. Materials and methods. Consecutive eligible patients treated with inhaled nitric oxide for a primary respiratory indication in the PICU or the cardiac ICU of the 8 institutions between October 15, 2015 and October 31, 2016 were included in this study. And the inclusion criteria was all patients with age less than 18 years and mechanically ventilated either before or within 24 hours of inhaled nitric oxide. Because there were few patients, around 2 patients here, inhaled nitric oxide was started before intubation, and they were included in this study. The exclusion criteria. Because we know that some other factors can confound the results. Some conditions, if they are pre-existing in the patient, that might confound the result. So they excluded newborns with congenital diaphragmatic hernia, meconium aspiration syndrome, or persistent pulmonary hypertension of the newborn. Or if the patient had started the inhaled nitric oxide in the institution outside the research network. Also, patients with chronic pulmonary hypertension or who were intubated more than 24 hours after initiation of inhaled nitric oxide were excluded from this analysis. Data collection began at the time of inhaled nitric oxide initiation and continued daily until 28 days or discharge from the PICU or death, whichever occurred first. Immediately prior to inhaled nitric oxide initiation and for the next 48 hours, all changes on the mechanical ventilator setting, blood gas measurements, and the dose changes of the inhaled nitric oxide were hourly collected, as well as the pulse oximetry and the untitled CO2. So as we can see that clearly, all the important parameters which can affect the oxygenation of the patient, they are collected. Also, they are calculating the oxygenation index or oxygen saturation index and the ventilator-free days. Echo reports were abstracted to assess the presence of pulmonary hypertension. And here in this study, they defined that the patient is having pulmonary hypertension if the TR is more than 3 meters per second. Also, they assess whether the patient had right ventricular dysfunction, TR, tricuspid regurgitation, and the presence of any atrial shunt and congenital heart diseases, because they are going to affect the oxygenation of the patient as well as the outcome. And then clinician responsiveness was assessed in patients who sustained or achieved adequate oxygenation. Adequate oxygenation here in this study was defined either your patient will have a saturation greater than 88% or the PO2 more than 60 within 24 hours of initiation. Then they will see after we have this sustained improvement, the clinician started to wean the FiO2 for the patient or no. We assess also the oxygenation improvement defined by 20% decrease in the oxygenation index or oxygen saturation index within 24 hours of inhaled nitric oxide initiation. Clinician responsiveness, as I mentioned earlier, was defined as timely if the FiO2 was reduced to less than 0.6 by 24 hours, and it is delayed if greater than 24 hours, or no response if the FiO2 was never reduced to 0.6 or less. So here we are seeing once the patient, you started your patient on inhaled nitric oxide, then the patient starts to show improvement in his oxygenation. Then the caring physician, once he starts wean the FiO2 to below 0.6 by 24 hours, this we define it as a timely response. But if the clinician did not, he likes the high saturation and he did not move the ventilator setting, did not wean the FiO2, so this is no response. Or he took more than 24 hours to wean the patient, also this is detected here in this study that it is not a timely intervention. So here, this table, table 1, will show us the demographic data of the patients. There was a male predominance in this data. Males were 55%. And also they categorize the patients by their age. Neonates, where if they don't have the pre-mentioned condition, the aspiration, the persistent pulmonary hypertension, they were included here, and they were subdivided by the gestational age as well. And then children, infant below 1 year were around 31%, and children below 12 years were the majority here in this study. They were 54%, while adolescents were 11% only. And also they include different races, white, black, African, or other unknown, and the ethnic background of the patient. And also they included the presence of chronic diagnoses, such as patients with chromosomal abnormalities, those who are having malignancies, lung diseases, organ transplant, and then pre-hospital technology dependence. What we mean by pre-hospital technology dependence, that if the patient, for example, had a tracheostomy tube in place before the admission to the PICU, before the enrollment, or the patient was receiving home ventilation also before the enrollment in the study. And those who have echo also, yeah, around 21% of the patients echo was obtained within the first 12 hours. And then if there was any cardiac catheterization, because here in this study, they included some patients from the cardiac ICU. For the 2 patients, there was indication to do a cardiac cath. The first question, are the results of the study valid? Was a representative group of patients completely followed up? Was follow-up sufficiently long and complete? I will say yes. The representative group of patients were adequately and completely followed up. They followed the patients till they were discharged from the ICU or till death, or 28 days. So this was sufficient to decide about the patient's outcome. That hospital and ICU length of stay was available for 100% of the patient to test the hypothesis and address the primary outcomes of interest. What are the results? During the study period, they included 151 patients with a respiratory indication for inhaled nitric oxide. And initiation occurred almost exclusively in the ICU, 140 in the PICU, and 10 in the cardiac ICU. The median time from hospital admission to inhaled nitric oxide initiation was 72 hours. 10 patients received inhaled nitric oxide before intubation. The median time from the start of mechanical ventilation to inhaled nitric oxide initiation was 30 hours in the patient who had mechanical ventilation before inhaled nitric oxide. The median duration of inhaled nitric oxide use was 4 days. The primary indication for inhaled nitric oxide initiation was the acute respiratory failure without elevated pulmonary artery pressure in 141 patients. Elevated pulmonary artery pressure in 5 and other or unknown in another 5 patients, because primarily they look at the patients who are having indication for starting respiratory indication for starting inhaled nitric oxide rather than the cardiac. And here, this is one of the important tables. It shows us ventilation and gas exchange at inhaled nitric oxide initiation with day 28 mortality. So here in the first column, we are looking into those who did not survive. The total number was 45 patients who died, and the survivors, the total number of the survivors were 106. And here, the other variables that can affect the mortality also they studied. What was the mode of ventilation? Was it conventional or high frequency? The partial pressure of oxygen, the saturation, the entitled CO2, the mean airway pressure, and the peak inspiratory pressure, and oxygenation index and oxygen saturation index. So here, if you look at those who were having a conventional ventilation, the mortality was 27%, while those who survived were the majority, 72%. And those who were in the high frequency, mortality was around 40%. The total number of patients who received high frequency was 15. And 6 of them died and 9 of them survived. And then the partial pressure of oxygen, there was no big difference in the PO2. The median was 67 in non-survivors compared to 64 in those who survived. And then the saturation, also there was no major difference between survivors and non-survivors. If you look at the map, mean airway pressure, there was a statistically significant difference between non-survivors and survivors. Those who did not survive, they were having a higher MAP compared to those who survived. And for the FI2, there was no major difference. For the PEEP, the median PEEP was 12 for the non-survivors, and for those who survived was 10. And the peak inspiratory pressure was around 33, slightly higher than those who survived, with the median was 32. And for the entitled CO2, there was no big difference, and as well for the oxygenation index and the oxygen saturation index. So the only significant parameter was the mean airway pressure, mean airway pressure. Mechanical ventilation variables at inhaled nitric oxide initiation for the survivors versus non-survivors are listed in the table we just have seen. And as we mentioned, the median MAP showed a significant difference and was higher among non-survivors. The median tidal volume, there was no big difference. It was 7.5 compared to 7.9 between survivors and non-survivors. And the initial, as we mentioned, oxygenation and oxygen saturation indices were not significantly different between survivors versus non-survivors. This is another table which shows us ventilation and gas exchange and at initiation of inhaled nitric oxide based on the oxygenation improvement. So here, the first column show the non-responders. Those patients you initiated inhaled nitric oxide, but there was no improvement in their oxygenation parameters. The second column shows us patients who showed oxygenation improvement, and the third column, patient whom we were not able to determine whether there was improvement or not. So if you look at those who received conventional ventilation, majority of them responded very well and showed oxygenation improvement, 87%. And those who are on high frequency, all of them, they showed good response or improvement on the oxygenation. Not applicable, there was the 3 patients, they could not find either the saturation or the PaO2, so that they cannot determine whether there was improvement in the oxygenation or not. And then if you look at the saturation, the median saturation for those who did not show any improvement was 79, but it was higher on those who are showing improvement with the inhaled nitric oxide. The median is 93. And for the inhaled untitled CO2, there was no big difference between the responders versus non-responders. If you look at the mean airway pressure, there was a difference between those who did not show a response and those who responded. Here, if you look at the mean map, the mean map was 13 for those who did not show any improvement in their oxygenation, but it was higher in those who showed improvement in oxygenation. It was around 19, the median. And for the PEEP, there was no big difference. The only parameter which shows a significant difference was the PO2 and the mean airway pressure. For the PEEP, although if you look here, the median PEEP for those who did not show improvement with inhaled nitric oxide was 8.5 compared to 10 in those who showed improvement, which means that higher PEEP use. And then for the other parameters such as the peak inspiratory pressure, entitled CO2, oxygenation index, and oxygen saturation, there was no major difference between those who responded to inhaled nitric oxide versus those who did not respond. 130 patients achieved or sustained an oxygen saturation greater than 88 or a PO2 more than 60 by 24 hours. Which means that they showed a great improvement in their oxygenation. Oxygenation responsivity was not different between patients on conventional versus high frequency. As we have shown in the table, both of them showed a good response. All those on high frequency, they responded to the inhaled nitric oxide. And 87% on conventional, they showed improvement with inhaled nitric oxide. 100 patients were receiving inhaled nitric oxide at 48 hours after initiation, while 8 patients died and 43 patients were no longer receiving inhaled nitric oxide. A responder had higher, as we mentioned, MAP, PEEP, and oxygenation index or oxygen saturation as compared to non-responders. The use of advanced ICU therapy was higher in this cohort, with 23 patients receiving ECMO, and 22 patients received CRRT, and 46 patients died in the ICU. We will see these advanced therapies in the next table. So if you look here, if you look at the ECMO, the ECMO use, here, the first column is showing you the number of patients who are showing no improvement in their oxygenation. And the second column is showing you those who had improvement in their oxygenation. Among patients who are having, who had ECMO, 4 patients did not show improvement in their oxygenation after initiation of inhaled nitric oxide, and 18 patients showed improvement. And then for the other things like cardiac arrest, it occurred on 4 patients who did not respond, and 13 patients among responders. And then the use of CRRT among non-responders 2, and among responders around 19 patients received CRRT, which is significant number. And then the ICU mortality, the mortality was higher among non-responders to inhaled nitric oxide, and this clinically makes sense. Maybe they were more sick patients, and 24% among the responders. And the length of stay also among it was the length of stay was longer among survivors, because those who died, they stayed less because they died earlier in the course of the illness. And if you look at the ventilator-free days, was more on those who survived.
Yes, Dr. Salma.
Yeah, I want to move to the next slide. Just 1 minute. My computer sometimes.
Maybe you can put
patient, we went already. Patients who responded to the inhaled nitric oxide have significantly lower mortality compared with non-responders. Among PICU survivors, 21 of 106 patients had new morbidity defined as increase in the functional status score by 3 or more. And the development of new morbidity did not differ between responders and non-responders. And the median length of stay in survivors responded to inhaled nitric oxide was 21 days. As I mentioned earlier, it was longer than non-survivors. And then this one can be explained that the non-survivors, the survivors, they died earlier in the course of the illness, so they stayed less. And this is another important table. This one of the, as we mentioned earlier, one of the outcomes studied in this research, they studied the clinician response to oxygenation. So the outcome here, this table 5, showed outcome associated with clinician response to oxygenation improvement. So here the first column showed us when the clinician had no or delayed weaning of the FI2, and then the second column is when the clinician had a timely response, mean that within 24 hours of improvement, they started to wean the FI2 for their patient. And then the third column showed when you are not able to determine. 0. This one, sorry, the total number is 2 for those who we were not able to determine whether the clinician started to wean or not. So the ECMO use was 2 for no response or delayed response, and 16 for those when the clinician timely weaned the FI2. And based on mechanical ventilation, and it is clearly one of the parameters that was affected by the weaning of the FI2 on the correct time is the ventilator-free days. The ventilator-free days was longer on those when the clinician timely weaned the FI2, but it was shorter for those when the clinician did not wean. So this maybe it can impact the practice, because as we know that hyperoxia can adversely affect the patient, and then maybe the patient will need more mechanical ventilation. For the other parameters, the weaning of the FI2 did not impact them. Even the mortality was not affected by the timely weaning. Only the only parameter which was affected by the timely weaning is the ventilator-free days. Clinician responsiveness, as I mentioned, was associated with more ventilator-free days when compared with patients for whom the clinician had delayed response or did not decrease the FI2 to 0.6 or less within 24 hours. 104 patients had echo performed during the study period, with 69 patients having an echo in the first 12 hours before initiation of nitric oxide on the study day 0. 29 patients had the evidence of pulmonary hypertension documented, with 17 patients echo detecting pulmonary hypertension at or before initiation of inhaled nitric oxide. Mild right ventricular systolic dysfunction was observed in 16 patients, and 8 patients had moderate to severe right ventricular dysfunction. As I mentioned earlier, this is what makes this study also interesting for me, that they looked in the right ventricular systolic dysfunction. Patient characteristics such as the diagnostic category and immune suppression were not associated with response to inhaled nitric oxide, but were associated with mortality risk. And this makes sense. We know that once you are having patients who are more sick, according to their diagnostic category, or those who are immune compromised, their probability to die is more. Then we will start to criticize our journal. Were all important clinical variables included? I will say yes. Here in this study, the investigators include all variables that affect oxygenation. They had the blood gas for the patient, they had the oxygenation index for the patient, they have the oxygen saturation index for the patients, they have the PO2 for the patient's the saturation. Also, they study other variables which may affect the outcome, such as the need for advanced ICU support, as well as diagnostic categories. What I mean by the advanced ICU support, ECMO, the need for ECMO, the need for CRRT, these things. Did the investigator test the independent contribution of each variables? Yes. They have multiple tables. Actually, I did not include all the tables. They have multiple tables by the subcategories of diagnosis also. And they analyze the outcome with each important clinical variables. Example, the presence of pulmonary hypertension, the mode of ventilation, and diagnostic subcategory. Does this study improve your clinical decision? I will say maybe it might improve my clinical decision, because this study, as I mentioned earlier, drew my attention to assess the right ventricular function in the pediatric ARDS patient. And also it enforces that prompt weaning of FI2 when the patient oxygenation start to improve play a key role in the outcome. But of course, we cannot generalize the study findings here, because they don't have, this is only a cohort study, they don't have a control group. So I cannot guarantee that if the same experiment is repeated in another group of patients, it will give me the same result, because I should have a control group and then a study group. When they are subjected to the specific intervention, then I will see what will happen to the new group of patients. But this study was one of the best models that I have seen for studying an intervention that affects the oxygenation, because they include all important variables. And then what we can conclude from this study? We can conclude that the only ventilator variable that differed between those with and those without oxygenation improvement at initiation of inhaled nitric oxide was a higher MAP. So it tells me that adjusting your ventilator parameters and mode, sorry, not the mode, only the ventilator parameters will impact whatever ancillary treatment you are using. And the finding that clinician responsiveness was associated with more ventilator-free days suggests that such an approach may be beneficial, as hyperoxia in acute lung injury has been associated with longer duration of mechanical ventilation and length of stay. And every intensivist is interested to lower the morbidity, mortality, and the mechanical ventilation duration for his patients. So it means that once you are having a prompt response to your patient improvement, this can impact the outcome of your patient. And the presence of moderate or severe right ventricular dysfunction, but not pulmonary hypertension, was associated with higher mortality. So it means that it is of value if you assess the right ventricular function while your patient is having and ARDS. And this will end our presentation, and we all work for a better future. And now it is
Thank you, Dr. Salma. If any colleagues have a question, kindly just raise your hand and unmute yourself. So any colleagues have a question or comments? Thank you for all. We have many colleagues who joined us from the other hospitals, so we will be glad to share their multi-center also experience in this regards. Anyone has a question or comments? So what did you mean, Dr. Salma, by the map, the higher map is the only thing that was really associated with responsiveness to nitric oxide, correct?
Yeah, because one of the tables here in this study, if you look at the parameters, because they compare those who responded to the initiation of nitric oxide versus those who did not respond, and then they check the various variables. They look at the mode of the ventilation, they look at the map, they look at the oxygenation index. Only a higher map, when you are using a higher map, this was significant, statistically significant parameter, which impacted the improvement on the oxygenation.
What about if the patient had no nitric oxide? Maybe with that higher map, he would have chance. So I'm just thinking over here. Is it a shared factor, both the higher map and the nitric oxide, or is it the higher map that made this change?
The higher map, because both of them we use the nitric oxide, but here we have one group, they did not respond to the inhaled nitric oxide, and one group they responded.
Yeah, I mean, what about if you have another patient who's not on inhaled nitric oxide and a higher map? Maybe he will have a responsive issue with the higher map already, with the lung recruitment.
Yes, this is what I mean when I said I cannot generalize the outcome of these results for another group of patients, because you have to have a control who were not subjected to the intervention. So you have to have a control group. They have the higher map, but they were not subjected in the to the inhaled nitric oxide. So to see whether map alone can improve the oxygenation without the use of inhaled. But here, because only, so there was no control group whom you can compare.
I see. Okay, we have Dr. Adib Khawaji. تفضل دكتور حكيم.
السلام عليكم دكتور، يعطيك العافية على البرزنتيشن.
وعليكم السلام.
بس سؤال سريع دكتور الله يسعدك. Do you think إنه ال INO should be bridged as a treatment for hypoxemic respiratory failure before trying the high frequency for pediatric patient?
The answer is no, because we know that high frequency by itself is one of the tools for the lung recruitment strategies. So maybe if I started my patient on the high frequency, I will show improvement without the need of the nitric oxide. We know that the role of the nitric oxide, it is a selective pulmonary vasodilator, so it will improve for me the VQ mismatch. So if I started the high frequency and my patient failed to show improvement, then I can do adjunct therapy such as the inhaled nitric oxide.
Thank you, Doctor, for clarifying this information, because in your study, in your presentation, you passed by a point where you said they use INO with conventional prior to high frequency, and they found with conventional even more responsive. So I was surprised, is this information is validated in your centers or not, or just presented as information in the study?
If you look at this table, this is the table showing the oxygenation improvement in the patients. All patients on high frequency, or they responded to the inhaled nitric oxide. And also in those who are unconventional, there was great response to inhaled nitric oxide, which is 87% of the patients. They can improve their oxygenation, but we cannot tell that we have to use the inhaled nitric oxide. We have to use all the other things that can help on the oxygenation. If we fail, then we can try the inhaled nitric oxide.
Thank you.
Thank you, Adib. Any other colleagues have a question or comments? So from other centers' experience, how's the nitric oxide with you with the pediatric ARDS? How do you feel that? Anyone had any recent work on it, or what about those with the COVID patients? I don't know if, although we are not having that extreme cases in pediatrics, but any other centers had, since we have colleagues from all over the PICUs.
And for me, Dr. Hani, Adib again speaking, when I reached to the high frequency and I struggle, and I reached to the level that I want to add on the inhaled nitric oxide, I'll bridge the thoughts to is ECMO is valid option for this patient or not, because still my belief is I know is good one for vasodilator and relaxing the right ventricle. But I think so if I reach to the level of hypoxemic respiratory failure, failed all modality of ventilators, while I'm bridging the thoughts of INO, I'll bridge the thoughts of validity for the ECMO patient or not.
You are having respiratory ECMO in your center, Adib?
Yeah, we have.
You have, excellent, excellent. Well, the issue is for other centers where we don't have that facility. So maybe we know before there was some portable mobile ECMO services, but I don't know whether it's launched for the pediatric nationwide. But you are right. Once you go to those patients who go with the severe hypoxemic failure, you are on a high settings on the high frequency. The earlier you prepare for the ECMO, the better, I'm sure. Thank you, Adi. Any other suggestions or thoughts from other colleagues? And from our residents, fellows, what's your experience? How probably you have noticed between the nitric oxide use in PICU versus that in the NICU when you are rotating as residents. Anything that comes into your mind after seeing this presentation today? Okay, so any issues you want to conclude, Dr. Salma? What about the roles of the echo? Will you go ahead and do an early echo for these patients?
The answer is yes, because here they mentioned here in this study that the severe to moderate RV dysfunction was associated with higher mortality. So once a parameter will affect adversely my patient's outcome, I have to check for it early. I have to check for the so this will change my practice that I will ask for echo for those who are having the ARDS early.
Yeah, I think so. That's one of the key learning points for our residents. Again, to think and plan these early, because the echo time arrangements may take time, especially now with our logistics. So always, once you plan to do it, think about it early. Okay. If no other comments or questions, I thank you all for attending our academic activity and wishing you all the best. Assalamu alaikum. I think we're gonna conclude now.
Okay, so we will